By day, this yellow, rickety pickup truck is meant for moving heavy loads, mostly firewood, from one village to another around Jalid community in Kano State. By night, it is on standby, an emergency ambulance due to the lack of standard healthcare facility to carry anyone unfortunate to become a patient in need of emergency care. To bridge the gap and to remove financial barriers in accessing primary healthcare services, particularly for the poor and vulnerable like the residents of Jali community, the Nigerian government in 2019 rolled out the Basic Healthcare Provision Fund. Called BHCPF, it is enshrined in the 2014 National Health Act. It is a pool funding with at least 1% of the country's consolidated revenue and other funding sources, including donor contributions. Almost 3 years into the implementation of the fund, journalists, with the support of the International Budget Partnership and the International Center for Investigative Reporting, visited hundreds of PHCs across 120 local government areas in 12 states of Nigeria to access the impact of the fund.
It has helped a lot in terms of maternal and child health mortality rate, because some children who has never had access to this facility, since this package came, they have been coming.
For the fund to get to beneficiaries, it is disbursed through the 3 gateways: the National Health Insurance Scheme, the National Emergency Medical Treatment, and the National Primary Healthcare Development Agency. Funding through the gateway of the National Primary Healthcare Development Agency consists of funding for essential drugs, vaccine, and consumables.
The manpower, like the Asia people, they do give us a fund buying drugs. So we have drugs. That one is not a case. People are coming.
Secondly, it's targeted at the maintenance of primary healthcare facilities, equipment, and transport.
The time when our roofing was very bad. Here was very bad. I will show you where look at it here. It was very bad. Our frontage was very bad. So we decided to do some minor remove the ceiling.
We have borehole. We repaired our borehole 2 times. We have these very windows. This Amako window is now the one we are doing. That's at hand.
Lastly, it is geared towards human resource interventions for primary health care. 5% of funding for human resource through the NPHCDA is for midwives. In 2009, the federal government introduced the Midwife Service Scheme. The MSS was designed as a collaboration among the 3 tiers of government: federal, state, and local government. Its major hallmark was having midwives deployed to primary health centers. Community health extension workers, or CHUs, were also recruited and deployed. The MSS appears to have had significant impact, but nearly a decade later, the primary health centers are facing a shortage of midwives. In states like Ebonyi, the scheme is almost non-existent.
Yes. So the issue is this. When we started with that fund. The federal will give you a part of the fund that you will use to pay, and we engage about 310 candidates to participate. So, but in the course of payment, we were not able to pay them regularly. So we paid them about 4 months or so. So After that, we weren't able to continue the payment, so we were owing them. So, as I'm telling you now, we have disengaged them, but with intention, which we almost concluding, to reduce them based on what we agreed with the national to 80.
In 17 PHCs visited across 5 local government areas in Nasarawa, more than half of them have no midwives, and the few that did have one, at most 2.
We have almost 3,850 people estimated for now in the community. And I am the only staff working in this facility. There is no manpower. I'm facing a lot of challenges due to my health, leading me to high BP because of the stress of work. Like this immunization is not a one-man work. It's a group of health worker work, but I'm the only person providing the services of routine immunization in the facility.
The experience is no different in Oyo State.
How many trained person? Because we learned we lack staff, not just here, another place. I don't know how it is for you.
Only one. Only I alone is working here.
We only have ad hoc staff here. We are only 2 training here. But due help of WDC, we could have another. We are having another staff.
Jigawa is also suffering from the death of midwives. However, the government introduced the sustainability scheme to bridge the exit of MSS in the state.
Ina morning duty, ina aikin safa ne kuma an jima da rana akwai wadda za ta zo ta karbe ni Hawwa'u Zubairu. Ita ce take aikin yamma kuma bayan aikin yamma ta gama mai aikin dare ita ma za ta zo ta karbe ta.
This is not without its challenges, as the midwives are asking for improved welfare. Poor remuneration and delay in payment contributed to death of midwives in many of the PHCs visited. As at October 2021, only Lagos, Kogi, and Rivers states were not verified to access BHCPF. Among the 34 verified states, only 31 were authorized to receive funds. The funds are paid quarterly.
The money was paid in 3 times. First quarter was 601, whereby second quarter was 200. Third quarter was also 200. That's how it was paid.
A curious factor militating against the implementation of the BHCPF in several primary health centers is non-availability of checkbooks. Yakasuwa and Ungwagini PHCs in Kano confirmed receiving funds but are unable to access it. The PHCs have become playgrounds and marketplaces for residents. Kano State Primary Healthcare Management Board says it has asked the bank for refund. Calabar, the capital of Cross Rivers, has cases of primary health centers operating without structure. One of them, in Bogobiri, operates services in hallway of a church. It comes amidst allegations of misappropriation of funds by the Director General of the Cross River State Primary Healthcare Development Agency, Dr. Janet Akbayong. In one instance, she was accused of directing that 80% of capitalization to health centers be paid to a company owned by her husband. When contacted, Dr. Janet Akbayong said the money was meant for the purchase of laptops for the facilities and that she presented the company because the laptops will be cheaper from them. Lack of structure was also a challenge in many states, prompting some communities to put in effort to rescue their health centers in some instances.
Give them a place to stay and do that for those who come for the day, because they don't come every day, but they have a number of days they used to stay before they come for antenatal, which the day which will give the town crier notice to announce that everybody should come to antenatal so date.
In some other situation, it is a lack of awareness. Beneficiaries selected for the fund or scheme are not aware of the program. Even where the beneficiaries are aware, lack of drugs is a challenge.
We haven't enough drug. We have equipment, but not enough.
So the last time they lost something in Logan, trying to lose a baby. So wọ́n fún mi ìjọ yẹn mo ní mi ò wọ́n lábẹ́rẹ́ ló wà kò sóògùn. Then later wọ́n ṣàfihàn ní anti-malaria.
Wọ́n fi ní anti-malaria. Okay. Wọ́n ní
lógún wọn lẹ̀.
Gbógun ti tán.
Gbógun ti tán.
Health facilities in areas considered hard to reach are in sorry state, despite receiving the quarterly allowance. They suffer from bad roads, lack of water, power supply, and recurring cases of leaking roofs and ceilings.
Don't have no water, no electricity, nothing. Because if we have a structure, then talk about infrastructure.
In one case, a health center resident said was effective at providing services was abandoned. The problems with the roofing.
Almost 2 weeks, I'll be buying this the fetcher. That is, we buy it and they're drawing the water, the thing will just fall inside. So, in fact, the thing has been giving me serious wahala. I've been thinking, how am I going to tackle this issue of water? But if you look into it, find out that it's not what basic health money can do.
Some PHCs are receiving the fund for the first time in 2022. Lack of awareness, failure for enrollees on the fund to pick up their registration cards, and mix-up in the list of enrollees stalled the implementation of BHCPF in many facilities. The BHCPF fund had the roadmap to achieve at least one functional public or private primary health facility in each political ward, then scaling it up to 30% of all wards over 3 years and further to 70% within 5 years, and ultimately 100% within 7 years of implementation. This means at the pilot stage, the one PHC per ward was adopted. While this helped to deliver healthcare to enrollees, it has also left other vulnerable individuals feeling abandoned and wondering why they cannot benefit. Experts warn that this approach may lead to the government focusing primarily on selected PHCs while leaving others in neglect.